Assalamu alaikum warahmatullah. Good morning, good evening, wherever you are. I'm Dr. Toha Sayed, Assistant Lecturer of Anesthesia and the ICU, Cairo University, and today's session is one of the most important sessions regarding physics related to anesthesia. It's talking about or discussing our topic about anesthesia machine ventilator. So, why we are using anesthesia machine and mechanism of anesthesia machine, and this will be paving a pathway or paving our road towards anesthesia machine modes and graphs in the next two sessions. So let's go and start. Okay, all previous sessions we were talking about spontaneously breathing patients. So why we are going to controlled ventilated patients using ventilator machines? Let's start with using a reservoir bag. The reservoir bag, as this is our circuit, here is fresh gas flow going into our circuit in an inspiratory limb, and here in expiratory limb at the end of expiration. If I'm going to give this patient his own breathes, so I need to open the inspiratory valve and closing the expiratory valve. At the same time, the ABL outflow valve should be closed, and I will use my hand to give the positive pressure inspiration to this patient. Okay, and during its expiration I will release my hand in order to let this bag to inflate it with the expiratory air and to let ABL valve to let the excess air in the circuit to go out. So from here, if we have 10 breaths per minute for 60 minutes, so I need to give this patient around 600 breaths manually by my hands, which is impractical and it will be so difficult. Here we need to replace my hand on the bag, and I need someone to control this valve. From here we get the principle for positive pressure ventilation using ventilator. During using ventilator, during inspiration, we have a bellow replacing this valve, this bag, which is powered by a fresh gas flow or gas driven. During inspiration, it's pushed by a special pathway or special path coming through a ventilator control, allowing this flow with the 45 psi to pressure against this pillow and gives the patient his inspiration. And during expiration, a control valve will be stopping this air or this flow to coming to the pillow, and another way will be opened and allowing this pillow to be expanded by patient expiration, and this pillow will replace the bag. At the same time, the ABL valve will be controlled also with this ventilator control directly, and this pressure gas is, if the positive pressure of 45 psi is applied on passing through this ventilator control, so it will be transmitted to this valve, it will be closed. But if this patient is during expiration and the ventilator control doesn't feeling the sensation of the 45 psi, this the pressure here it will be released. So if this pressure is released, you can go outside directly, releasing the pressure inside the circle. So if we are having here two openings to the open air, which is near the ABL valve and at the ventilator control. This will be later connected to a system named scavenging system, and this scavenging system will send this gas safely to outside of the hospital. So we have replaced the hand of the patient, or the hand of the doctor, with this bellow, and we have replaced this ABL valve with an electronically controlled valve. So sometimes with this ventilator relieving valve, here in mechanical ventilation will be named ventilator relieving valve, not ABL. With so this ventilator relieving valve is controlled by the pressure of this ventilator control, but during expiration the pressure here will be zero. Sometimes in some ventilator you have uh, pressure at this area around 2 to 3, and this is applied by some machines in order to decrease work of breathing on the patient. Some, if you make the positive end expiratory pressure, the beep, zero, and you can find in some machines that the beep is around 2 or 3. This is a mechanism inside this ventilator or this machine to allow or helping the patient to open this valve without work of breathing. So we have now two types of ventilators, two types of pillow classification. Okay, the ascending and descending pillows. And to know that if this machine is ascending or descending pillow, you look at this pillow at expiration. At expiration, this pillow is filled with air, so in ascending it will ascend, but in descending this pillow will descend. In inhalation, the driving pressure will press on this pillow, so it will give the patient his inspiration volume, his tidal volume during inspiration, but the driving gas is coming from downward in the descending below. Here we have a very common question, which is better, descending or ascending? Ascending is better than descending. Why it's better? Because it's more safe. During this connection, you can detect that this pillow is pressed downward by driving gas. There is no expiratory gas to allow this pillow to ascend. Unlike the descending one, it will descend by gravity. After and during inspiration, it will give the driving gas will push the air, descend by gravity. So the patient will have disconnection, but this pillow in descending pillow will work as if there is no disconnection. Okay, here regarding ABL valve or ventilator relieving valve, and after this pillow and the air or driving gas leaving valve will be together connected, as I said before, to a scavenging system. Okay, so we have here a very common question: enumerate ventilator classification, or how can you classify the ventilator? We have different classifications, around 4 or 5 classifications. We'll start with the first classification, which is depending on the power source. We have 3 types of power source: the compressed gas, electricity, and mixed compressed gas and electricity. In compressed gas, we have here our example is mainly ventilator and balloon filled ventilator. These ventilators are using the gas to work, they don't need electricity to work, and they are used in remote areas and war fields because they only depend on driving gas. For example, in mainly ventilator, here we have an adjusting bar which is used to adjust the tidal volume of the patient. Okay, and it will trip from to upward to this area. The fresh gas flow is coming from this side. It will push the pillow upwards till this needle or this adjustment needle hit a metal bar. It will stop moving upward. Here we have a load or a mass or a weight at the top. When this needle stop, it will push this pillow downward, and it will push air in inspiration to the patient till the pressure valve here become equal to the pressure inside or reach the equilibrium inside the patient. It will stop inspiration and it will repeat giving the air and the needle going upward till it hit its limit, and again it will push air against with this weight, with the force of the gravity. Okay, balloon filled is a very common device. You only adjust inspiratory and expiratory time and the flow. When you switch it from on to off, it doesn't need from off to on, it doesn't need any electricity. It will start pushing the gas or the fresh gas flow without the need of any electricity. This device is not safe and you cannot use it in major or critically ill patients. You have no alarm. You cannot detect disconnections because it will give no alarm during disconnection and it will continuously push the inspiration and expiration even if there is a disconnection, and you are calculating the respiratory rate using manual calculation. You cannot control the respiratory rate with a button or any controller. So they are only used in remote areas and war fields for fast delivery of an operation for a soldier or something like this. Okay. The second type is electricity using a mechanism named piston ventilation, a mechanism going forward pushing a driving gas using this piston like an injection. It will push or press around this tube. It will push the fresh gas flow to the patient, and when it coming to the opposite or reverse side, it will suck the air from this tube, so it will create a negative pressure allowing expiration. The most common example for this is the dragger, but noting that here we have something like a pillow. This is not a real pillow. It's just coming to the with device to make to satisfy and familiarize and test with the new rule, with the new mechanism and devices invented by this company. So it has no rule, it's just moving upward and downward. And right now, most of devices are using both compressed air and electricity, as we said before. No current ventilators are using compressed gas alone, or use electricity for electronic sensor and computer control mechanism. As we said that this high pressure oxygen coming directly with 45 psi to push the air during inspiration, and it will be relieved from this valve directly to outside using scavenging system to release the pressure inside this canister to allow the pillow to expand or ascend and allow expiration of this patient. Okay, we have finished the power source classification. We have something named drive mechanism, how the drive gas driving air to the patient. We have three mechanisms using pillow like General Electric or GE devices. Okay, that is Omida. Both of these lines are independent from each other. They are not interfering together. Okay, and piston view like ventilator like the dragger, it's electronic derived piston, and turbine, which is using a turbine allowing to control the air from inspiration and expiration. It will go for a definitive way, for a definitive direction to allow inspiration, and reverse this direction to allow expiration using several valves during this circuit. Third type of classification is cycling mechanism. Previously, we were using pressure and volume control, which are depending on time, so it's controlled mode. But as we will know in the next two sessions, that the ventilator modes, new ventilator modes have been invented, and we are using spontaneous mode and the CPAP mode and BiPAP mode. All of these will depend on flow, or depending on flow and time together. We will learn that in the next two sessions. So if the question is coming, it will come like enumerates classification of machine ventilators. It will be classified according below classification: ascending and descending, and ascending is much better than descending for safety. Power source: compressed gas, electricity, or both. Drive mechanism: pneumatic, piston, or turbine. And finally cycling mechanism, which will be time cycled and flow cycled. Another important question in the exam is the problems and hazards relating to anesthesia machine. The most common and the most dangerous problem for anesthesia machine is the disconnection, and the most common site for disconnection is a white piece. The tubes can be disconnected at any side: inspiratory limb, expiratory limb, any side with junction can be disconnected, even the junction between the tube and the endotracheal tube. So beware of that. And the most common side for this connection is the Y piece, and for this reason this is an MCQ question: how to detect the anesthesia machine, or monitors anesthesia machine disconnection, or monitors for disconnection. The first and most important monitor of disconnection is the anesthetist himself, because you need to be full attention to the patient. You need to be attending during the OT. You don't have to leave the room during the OT or a working surgery. You don't have you shouldn't using your mobile phone during the ongoing surgery. Your ear should be musical in order to detect difference in tone during change the tone of pulse oximeter, and to hear the alarms as soon as they are announced. Okay, others monitors for this connection: apnea alarm, which can be uh, you can modify it according to specific time, which by default is around 60 seconds, and sometimes we do it for 30 seconds. The bellow: collapsing bellow only in ascending bellow, or sudden loss of waveform in capnograph. As I said previously, capnograph is the most important monitor in the OT, and sudden loss of waveform or this pattern could be two options, two differential diagnoses. The first one is a disconnection, and second one could be arrest. And finally, volume and airway pressure monitor. So this is the problems, the most common and most important problem and the most dangerous problem regarding anesthesia machine and its connections. The second problem is misconnection, and this is occurring by correct connection of inspiratory limb, and expiratory limb will be connected to fresh gas outflow, and this is very dangerous because there is no expiratory limb that will make a leak to the circuit. Excessive airway pressure. This can be because of obstructing the breathing circuit, which is a kink, especially if you are having two long tubes, or there is a problem in the ventilator relief valve, VRF. If you have a malfunction in this valve, you will be having an increasing in the pressure inside this circuit. Scavenging system malfunction will increase the pressure, and will having a decrease in pressure. We will discuss this alarm later. If we have something called sub-ambient pressure alarm, if we are using active scavenging system which are causing negative pressure inside the circuit, if this way is malfunction, we will discuss the scavenging system in a specific lecture for its own, because we have different types of this scavenging system, active and passive, and two mechanisms. But scavenging system, if we are having malfunction, we could have excessive airway pressure or we could have low airway pressure. Again, to have a problem for excessive airway pressure, we could have excess inflow, like oxygen pressing oxygen flush button, which will transmit the 45 psi directly from the tubes or from the cylinder to the patient, which will cause barotrauma or a problem in this pillow. So if we having a cracking or a tear in this pillow, the pressure coming from here is also by 45 psi. It will pass through the circuit and will apply some pressure to the patient, which will increase the pressure to the patient, which will could cause barotrauma or pneumothorax for this patient. Here the pillow assembly problem, which the leaks, as we said, if we have a hole inside the pillow, it will the pressure from this line will pass with 45 psi, or the seating plastic, proper seating of the plastic pillow housing, the housing itself having a problem, allowing leakage of this high pressure air to outside. Okay, regarding the problems in ventilator relief valve, which is acting like the ABL valve in spontaneous. If it's stuck in close, it will cause barotrauma. It will not release the pressure inside the circuit. If it's stuck open, it will cause hypoventilation, because during inspiration and expiration, it allows leak to come outside, which will make less air to stay, or less fresh gas flow to, or less gas to stay inside this circuit. So it will allow hypoventilation and could be associated with hypoxia. And finally, mechanical ventilator failure. And here we can shift. Some ventilators can allow manual ventilation with the circle system, but some other ventilators cannot allow this. If you are not allowed this by ventilator, you will have to use ambu bag with directly connected oxygen supply, and you will give the breaths by your hands. So here, as we said, here is two questions: enumerate hazards and problems related to anesthesia machine, and enumerate the sources or classifications for anesthesia machine. This is another question or a third question in the exam, which is ventilator alarms. We have different alarms, which are high pressure alarm, high peak pressure alarm, which is around 30 to 40 centimeter water according to setting to the patient. We commonly using 30 as our limit. And recently some devices having something named sustained ventilator pressure alarm, which is saying that you haven't interacted to high alarm for a period or for a time or for a duration or period of time. Low pressure alarm when the pressure inside the circuit decrease to below less than 10, and some ventilators less than 9. And as I said, we have something named sub-ambient pressure alarm, which is a negative pressure inside the circuit, and this happen only inside negative pressure applied by active scavenging system. Low volume alarm, especially in pediatrics, and high frequency alarm, apnea alarm, and we said that it can be modified according to needs. High beep alarm and low beep alarm. And recently some ventilators having an alarm named reverse flow alarm, and this is detecting malfunction expiratory valve during inspiration. It allows air to pass through this valve. So you can add it to your notes, reverse flow alarm. And here an oral exam regarding the accuracy at lower tidal volume. This is applicable especially for neonates and infants with low body weight. For example, if this neonate of 2 or 3 kilogram and we are going to have an operation for any dysfunction or malcreation or any anomaly happen to this patient, so we will need to maintain this to the patient. So we are having our the common what we are saying, the common example we have provided, that the machine is adding if we are giving fresh gas flow of 600 liter per minute, so 6000 milliliter per 60 seconds, so it will be around 100 milliliter per second, and our respiratory rate is 10 and IE ratio 2 to 4 seconds. So the addition to the device or to the machine will be around 200 each cycle. The old devices like Datix Omida we are using, you could find them in Kasraini in some theaters, having a problem that it will not give the 300 to the patient, it 30 milliliter for the patient. For this infant patient the maximum will be 30 milliliter. It will give him around 230 milliliter per minute, which is dangerous for this patient and will cause barotrauma. And these devices sometimes when you are giving the patient or trying to anesthetize a patient with a specific uh, tidal volume, for example 500 milliliter, and you have a high flow fresh gas flow around 10 liter, its pillow will go for more than 500, for example to 800 and 900. And this because the old module used in these devices, it cannot allow air to come out the cycle easily or the gas to come out the cycle easily. And to maintain this cycle at lower and accuracy at the lower tidal volume, we are going to something called electric compliance on an leak test, and this will be discussed later in anesthesia machine checking anesthesia machine session. And to maintain the accuracy we have two modes, which are decoupling and compensation. So decoupling mechanism is like in inspiration. Here the fresh gas flow is coming through this pathway. We have here a valve. In inspiration this valve is closed and the ventilator is giving the 30 ml for the patient. Okay, and at this time the circle will go as usual during expiration. But here we have another valve is closed during expiration, so this valve will open and allow to renewing the oxygen content inside this air and the renewing inhalational gas inside this. So again in inspiration this valve will be closed and this valve will be open and will give this air. In this mechanism the bag will be inflated during inspiration because of high pressure applied by the oxygen backward to here, and this oxygen will not pass to the patient from the other side because we have here the valve which will be closed during inspiration, and during expiration this bag will be deflated because this valve is open, so the pressure here will be relieved, allowing this bag to deflate. We have another mechanism, especially in turbine system, as we said, is compensation. The turbine will only provide the 30 milliliter to the patient, and it will not allow the air to having excess pressure to inside. Okay, so we have decoupling method and compensation method to deliver lower tidal volume. And finally, we have this device, Mackay flow eye anesthesia, which is using a mechanism which is used in the recently invented machines named volume reflector. This during inspiration, we will start with expiration. During expiration, the gas will come out, passing through CO2 absorber, carbon dioxide absorber, okay, and it will go inside this convoluted tubule which will named as volume exchange. Beep valve will be opened to allow and applying some beep pressure to the patient. During inspiration for this device, okay, the drive gas will allow pressure pushing the air directly towards patient's lung, mixing it with the vaporizer and CO2. This named volume reflector depending on the volume exchange tubes at this site. Okay, you should know the just mechanism for the oral exam. Do you have you used before the Mackay flow eye anesthesia? Yes. Do you know how it works? It's used. It's working by a volume reflector, and you should know this. He will not go to deep details for this mechanism. So, by this slide, we have reached our end of this session. Our next two sessions will be very important for all anesthetists, especially junior anesthetists. They should know how to read and deal with ventilator modes and ventilator graphs. So, till next session, thank you and see you later. Have a nice day. Bye.